Good afternoon, everyone. This is. Can the people at the last bench please sit down, or please carry on with your other activities, not inside the hall. Now, can we have that light down? We'll have the first speaker for this PG teaching session, Dr. S. Ambika. She's going to talk on the localizing the lesions made simple. Lesions, using the eye, localizing lesions anywhere in the body can be made simple. Your eyes and patient's eye, both. Thank you. Start now.
Good afternoon. So my talk is on localizing lesions. And we all know that in neuro-ophthalmology, there are two main complaints which do present to us: vision loss and diplopia. With this 15 minutes, I will try to do with the first one, and I doubt whether I could move on to the second. So we all know about this conventional drawing which we have come across in our med school, where we have this different types of field loss, which is probably going to localize the lesion. Instead of going like this, because we have seen it quite frequently, I'm going to do it on case-based approach. So any detailed history of a vision loss is going to help us where the lesion is associated with the other symptomatology what the patient presents with. So let me take a vision loss. So the vision loss can happen in any part of this entire visual pathway. So I have grouped it into an optic nerve and an immediate retrobulbar nerve, and the posterior optic nerve with the chiasm, and the tract and the radiations, and that of the occipital cortex. So we have grouped it into 4 type of diseases, and this is what is the entire list of causes which can cause these type of lesions anywhere in the visual pathway. And remember that at the level of LGB we lose the pupillary pathway, so any lesion which is higher above the pupillary pathway which is causing the dysfunction is going to show you a normal pupillary reaction. So all the optic nerve dysfunction test has to be performed in any patient with vision loss, starting from vision, color vision, to pupillary examination, fundus appearance, and the visual fields and the structural parameters. So let me go with case, and if there are postgraduates, you can join in and discuss. So this is a 30-year-old female who came with a sudden drop in vision in the left eye with a 6 days duration. And the vision in the left eye was counting fingers 2 meters, and she carried a visual field with her which she tried performing in the beginning, which had an advanced loss in the left eye, and the right eye was normal, and the color vision was normal in the right, but the left was impaired. So where do you think the lesion is? So this is the fundus appearance. So you see a disc edema in the left eye. So it is not only what we see in the fundus that is showing the lesion, but the next thing is the MRI. And what you see here is an coronal MRI with a post-contrast enhancement of the left optic nerve. The inflammation is not only settling with the level of the fundus, it's also behind the optic nerve. What you see here is a diffuse enhancement and a thickening of the optic nerve along with the sheath, periorbital sheath stranding, and a fat which is being bright. So you don't see generally this type of changes in an optic neuritis. And if you see something like this, remember there is a group of optic neuritis which are atypical. So this is a group of atypical optic neuritis where it turned out to be MOG, and the patient was a MOG antibody positive atypical optic neuritis, and post steroids they did better. So this is a 37-year-old female, again with a monocular presentation of one eye vision loss, but she gave a history of low-grade fever 3 weeks back and a headache. If you could see, the right eye is dropped in visual function and that of the left eye is preserved. She had a moderate drop, which is 618 N8, and she gave a brilliant history of TB in her brother with whom she is living. So when you get such history living in India, do not forget that we do also have an infective overlay of all the optic neuritis. So this is the fundus of that eye, which had a drop in vision, a significant disc edema, which was seen on the SSOCT2, and a dense inferior altitudinal loss. And that of the left eye was normal. So here, the lesion is again in the optic nerve, but if you see the location, it's not only in the diffuse optic nerve, it's more in the sheath. You could see that there is a bright enhancement of the sheath alone which can be picked up over here. So that is more of a perineuritis-like picture. That's an optic nerve sheath enhancement, what you see in this patient. So here the location is different, but the patient is again manifesting with the same presentation. And her systemic evaluation showed that, yes, she was also positive for TB, had an hilar adenopathy. So subsequently, we put her along with steroids a course of antituberculous therapy. And this is a visual field, and vision improved by 4 weeks. So this is a 47-year-old female who came with a history of painful diplopia, which was in the past, which improved with steroids. And she also had a sudden drop in vision in both eyes, left eye more than the right eye, which was painful diplopia, redness, and grossly restricted extraocular motility. And her vision was normal. And when you could see this, you can see that how much of engorgement, thickening, chemosis, redness, everything, say name it, you have all soft tissue signs, and her extraocular motility is grossly restricted in all directions. She did not have any history of trauma, so there was no bruit, there was no thyroid abnormalities. So this is the fundus. Again, we are seeing a bilateral disc edema. So where do you think the lesion is? The fields was having a very subtle central depression in both eyes. And this is what you see in the MRI. Here, it's not the nerve which you are seeing, it's more of the muscles. You can see the diffuse brightening up of the extraocular muscles, which is crowding at the orbital apex. And this is a type of thickening which is also extending to the tendons, which is not like a thyroid. So you see a diffuse engorgement of the EOM, soft tissues and everything causing an orbital compression. And here you can see the gross thickening of the extraocular muscle. So our provisional diagnosis was either a myositis or an IOID. And as a convention, we also get all the inflammatory markers. So post IV steroids, she did improve, but we went ahead and performed a muscle biopsy which showed a chronic granulomatous inflammatory infiltration with a significant granulomas in that was a sarcoid myositis. So here the disc edema was due to the extraocular muscle inflammation. So this is the post-treatment outcome of that patient post IV and oral steroids. So coming to the chiasm, any unexplained vision loss, headache, color vision difficulty in depth perception, and bitemporal field loss, you have to suspect a chiasmal syndrome. And there can be also a raised ICP, which is not that commonly seen in a chiasmal syndrome, but yet is it possible. When the lesion in the chiasm is going suprasellar, it starts compressing the third ventricle and you will end up seeing a disc edema. And you can also see sometimes endocrine features like acromegaly and gigantism. So this is a chiasmal syndrome disc. You can either see a temporal pallor or you can see a bow-tie pallor, which is not that commonly seen. In chronic chiasmal compression, you would end up seeing a bow-tie pallor. And as I said, you can also get a ophthalmoplegia sometimes when the lesion is going parasellar, because we all know that in the lateral wall of the sinuses, we have all the cranial nerves sitting over there, and any mass which is involving the paracella is going to result in vision loss as well as in a cranial nerve palsy. So this is one example where this guy was diagnosed elsewhere as a traumatic optic neuropathy. You could see the gross disparity on his face. You could see a gross enough, a displaced globe, a periorbital fractures, and he said that he has left eye vision drop for 4 years. And he said that left eye vision is worsening day by day. Well, that history doesn't go with a traumatic optic neuropathy. So this is the disc what you see. Definitely this is not a left eye optic disc which is having a 4 years onset of traumatic neuropathy. It's still pink. So this is the field of the left eye and that of the right. So where do you think the lesion could be? Fine. So the patient had only a CT orbit which had multiple fractures. So we went ahead an MRI and it showed a suprasellar lesion which is compressing the nerve as well as the chiasm, and that was the reason for his left eye vision. So don't go about just with the history where the patient had a trauma, had so much of deformity in the face, CT showing a lot of orbital fractures, but yet that was not the reason for the vision loss what he had, and that's the chiasmal lesion. And this is the post-treatment, post-neurosurgical excision. The patient had a very good visual recovery. Co-chair, you can stop me at the time when I'm shooting up. So this is case 5, which is a 41-year-old female who came with history of ptosis and squint for 2 years duration, and she was diagnosed elsewhere as thyroid eye disease, and she had a vision loss in the right eye also. What you see here, she has a squint. What you see here, there is a restricted adduction, and there's a restricted elevation, and there is a very mild ptosis in the primary gaze, and you see the lid is not following the globe in the right eye. So what is that sign called? That's the inverse Duane's with a pseudo 1 graphe, and she had a right third nerve with a chronic compression. She has developed an aberrant regeneration. So that's a right third, fourth, and an optic nerve. Definitely the level of lesion is at the chiasm, which was seen in this visual fields, having a dense temporal loss in one eye, and that of the left eye showing a superotemporal loss. So this is the lesion what I told, the cellar which is spilling over into the right paracellar area, and that's the cause. See, this is a classical dumbbell type of appearance. Cella, supracella, and paracella, the mass was extending. So post-treatment, the patient had a good recovery of the vision as well as the ocular motility. Coming to the retrochiasmal lesions, hemianopia, if you look into, you have to look into the congruity of the hemianopia, because any complete isolated homonymous hemianopia is non-localizing. Incongruous hemianopia will localize. The more anterior the lesion is, you will get an incongruous lesion, and the more posterior the lesion is, you will get a congruous lesion. So this is a complete left homonymous hemianopia, and this is an incongruous left homonymous hemianopia. So coming to the cause, you could read up in the textbooks, which is mostly vascular followed by trauma. So this is a 51-year-old male who was brought by the wife saying he's frequently falling for the past a week or so. So when we saw, he had a 6/6 vision, and anterior and posterior segment evaluation was normal, but this is the fields. What is the type of fields you see here? It's a right inferior quadrant anopic defect, what we call as a pie in the floor field. And when we imaged this patient, he had a significant left subacute bleed with a SOL and a surrounding cerebral edema. That man is lucky to have come this time because he didn't go in for a midline shift and pop off. So that patient was a only field loss showing up with a massive lesion in the brain. And this is again a 59-year-old male who had a sudden drop in vision in the left eye post CABG, and surprisingly after pandemic or while pandemic, everything was related to COVID. So post-COVID optic neuritis was the diagnosis what this patient came to us with. So his vision was better, but he said that his field did not recover after the steroid treatment. And when we saw the fundus, it was like this. And this field is definitely not only an optic nerve type of field loss. So this is a significant left optic, left side hemianopia. And this was his MRI, which showed a massive right PCA, MCA area subacute infarct. So this is the lesion which is causing that field loss and the disturbance for him. So this is a case which is a 65-year-old male who was brought to us for cataract surgery by his kid. And he said that from suddenly off late, he is not having a good vision. He is bumping into objects. We have brought him for a cataract. Well, that history is not something good, because the patient was having a PL vision which was not correlating, although he had a near total dense cataracts in both eyes. And he had a normal fundus examination and anterior segment. And subsequent VEP also showed a relatively good waveforms, but with a delayed latency. Still not able to explain the vision, we went ahead and MRI. So the MRI showed a right side subacute lesion with a left side chronic involvement, and that was a cortical visual impairment. So with this, I wind up with the vision loss, and probably I will move on to the conclusion slide. So detailed history taking is the key for an onset of symptoms and localization. Always associate other complaints like headache, pain, and the type of the field loss, which will help you in making the lesion localization, and correlate the vision loss to the clinical features, and differentiate retinal and other causes from optic neuropathy, and do ask for a contrast enhanced MRI brain and orbit, because there is very limited role of CT brain and orbit in neuro-ophthalmology. Thank you so much.
Thank you, Dr. Ambrika, for that wonderful talk on the neuro-ophthalmological conditions Generally, the problem with the postgraduates is the moment you say neuro-ophthalmology, they get too scared. But it is one of the most didactically available. You must know where the lesion is, what the symptoms are, what the signs are. Then it's very easy. Then you don't need sometimes MRI at all.
Exactly.
If you look at the ocular motility, lot of diagnosis can be made just looking at the ocular motility, and probably not MRI at all. But that was very good collection you have. Thank you very much.
Thank you.
The next talk will be Dr. Kalpana Narendran, who still is my good friend, but nowadays I have stopped operating on for squints. You will know after that why I stopped operating on for squint. Kalpana.
After my talk or
After your talk.
Okay, sir.
Disagreement doesn't mean we are not friends. We are still friends.
Okay, thank you. So, good afternoon, everybody. Thank you. Like sir was mentioning about running away from neuro-ophthalmology, the next, as postgraduates, we run away is strabismus. But it is, as a practicing pediatric ophthalmologist, I can say that it is very easy to deal with children. And strabismus, if you go in a methodical way, it is definitely a very easy specialty. So when you talk about strabismus, you have to first fix the goals of strabismus examination. So first thing will be to establish the cause of strabismus. So what is the reason for strabismus in this patient? And then there is a condition called pseudostrabismus, which we'll be discussing. Then the etiology, whether it is congenital or acquired. And then to rule out any restrictive pathology, because squint can occur because of many reasons. And most importantly is you have to assess the binocular motor and the sensory status of the patient, measure the angle of deviation, because that will give you an idea of how much to correct and how much to operate. And if there is an underlying amblyopia, diagnose the amblyopia, treat it first, and then proceed with the correction of strabismus. So history is very, very important. We all know for anything, the history is the foundation stone for making correct diagnosis, and a detailed patient history is the baseline for dealing with the strabismus patient. So in the history, what would you ask? One is the onset of strabismus. Is a child born with strabismus or it is an acquired strabismus? Because certain acquired strabismus, like if it's a third nerve palsy or a sixth nerve palsy, third nerve especially, which is a daytime emergency patient, because you never know, that might be aneurysm, patient would need immediate imaging. So that is very important, the onset. The second thing is and also in the onset, we have had patients presenting with an acute sixth nerve palsy will present as a esotropia in a child. I'm sharing my personal experience. This child, Shwati from Tirupur, I remember very well, came with the esotropia. Parents said she's got it for the past 6 months. And we did see her and everything was normal when we saw her. But later on, it was a internal hydrocephalus. So that was presenting a sixth nerve palsy. She had to have a shunt. And I lost the patient follow-up, but bumped into them later to know the history. So any acute esotropias have an imaging done and get a detailed history. And then the character of strabismus, because some of these strabismus can present later in life, or initially they would be intermittent, latent, intermittent, and then become constant. So the character of the squint is very important. And also to know that if it is precipitated after an episode of illness. Mostly the intermittent exotropias can sometimes be precipitated, or viral illnesses can present as sixth nerve palsy. And sometimes the other, superior oblique, fourth nerve palsies or nystagmus can present with a face turn or a head tilt. Again, more detailed history, you have to ask chief complaints, deviation of eye, spectacle wear, age of gestation, because prematurity can associate with presenting with strabismus. Family history, very important, because strabismus can run in families, especially certain syndromes like Duane's interaction syndrome can run in families, especially in women and more in the left eye. And then diplopia, if it's acquired strabismus, they can present with diplopia. And any history of patching, because amblyopia, the modality of treatment main is patching. And then delayed visual maturation. Sometimes children with cerebral palsy or other hypoxic encephalopathies can present with strabismus. And asthenopia, and any previous history of surgery, and any abnormal eye movements. So it's such a detailed history. And this is also very important. As strabismologists, we always talk as a fact test, the photo album test. Because you see this picture here, this boy at the age of 4 years presented with an esotropia. He was corrected at the age of 10 years, remained orthophoric, and later at 24 years, he presented with the consecutive exotropia. What was ESO of the left eye? It's become an exo. So this is very important. And also head turn. The head tilt, sometimes we pick up with photograph. This photograph, doctor, see all my pictures, I have my head like this. Or somebody would have noticed and said. So this is a very important test in, practice of strabismus. Then past history, if the child has already been treated by somebody, is there a history of patching? History of spectacle wear because accommodative esotropias, or even sometimes intermittent extremes or even constant extremes can be associated with myopia. Then the type of strabismus and blowout fractures. We're talking about restrictive pathology like blowout fracture, thyroids can present with a picture of strabismus. And any history of previous surgery, because detachment surgeries, glaucoma implants, cataract surgeries, your superior bridal suture can sometimes injure and cause strabismus. So probe into the history and detail history. And this is a set of instruments. Strabismus is a very simple practice. You don't need any high-tech investment to do strabismus surgery. You just need a good cover, a good target, and a good set of prism bars. These are loose prisms. These are horizontal prisms. These are the targets. And then we will show you the covers. But there are high-tech, like you have the Synoptophore, then you need a hair screen. The Synoptophore is not really in use now. And then the hair screen, of course, check for diplopia. And these are all very simple. Just check the depth of perception. We're talking about the sensory status of the patient. So you need to check the stereopsis, binocular single vision, and the depth perception. So these are the RAF ruler. So not a big investment for a strabismus practice. Then coming to the physical examination, it's very important to observe the patient. As the patient walks in, the teaching is you observe the patient. Also in neuro-ophthalmology, they say you can find out the field defect. You can make out, as the patient walks in, we can say whether it is a glaucomatis, or it is retinitis pigmentosa, or it is a cortical infarct. So as the patient walks in, you observe the patient. One is to look for any face turn or head tilt. The other one is to see the IQ of the patient. Sometimes these children are delayed, but the parents will deny that the child is delayed. So always assess the patient, which is very important. Visual acuity estimation also is the next important test. Sensorial evaluation, movements of the eye, measurement of deviation, and then all the special tests which I'll be talking about, cycloplegic refraction, and definitely a fundus evaluation. Again, a story to share here. Maybe I'll talk later in the fundus examination. A very healthy looking, share it now before I forget, a very healthy parent with a child, a chubby, beautiful child, came in with esotropia and then turned out to be retinoblastoma in one eye. So it's very important to have the fundus evaluation done in all your strabismus patients, a detailed fundus evaluation. So talking about the apparent squints, this is a patient where you have a prominent epicathal float with a flat nasal bridge can present as a pseudoesotropia. So always keep in mind that not all patients who present is true strabismus. Always keep in mind about pseudostrabismus. And pseudoexotropias, mainly because of positive angle kappa, they have a wide interpupillary distance, a telecanthus, which can present as a pseudostrabismus. And this is what I was talking about. You have a pointer here. Okay, this is you can see this child presented with a small head tilt, and there is a facial asymmetry you see on the left side. So this is what is the observation for. So the observation is very important because you need to see the, maybe I should play the video again. Can you play the video again if you can? See the facial asymmetry on that side? I don't know, it's not working. Okay, this side is a facial asymmetry. And always this question comes, does a child cooperate? Invariably, if you treat them in a nice way, and when you examine a child, what is more important is to get faith from the parents. The parents should be convinced. So never touch the child. Always, because sometimes children don't like the touch when you go and grab them. So that is very important to get the cooperation from the child. So patient's visual behavior, check for the eye movements, look for the ocular alignment, and head and face posture, like already mentioned, and milestones and IQ is very, very important. Then coming to motor evaluation, you will do careful measurements of the angle of deviation, and which is very, very crucial in planning your surgery. Another point is, if the child is very low, then how would you know that the child is seeing well? Is by looking at the fixation. The fixation is the monoocular and binocular fixation. In monoocular fixation, you occlude one eye and look for the point of fixation. If it's central, steady, maintained. If the reflex is central in the pupil, if it is steady and if it is maintained, it indicates that the child has good vision in that eye. If there is a drift, I'll talk about it in interpretation. So again, binocular fixation, you have to estimate the degree of preference of fixation. Again, alternating squints, dominant eyes. So all that is for binocular fixation. So this is again the interpretation. If the fixation immediately goes to the preferred eye, it indicates that there is a strong fixation of the preferred eye and there is probably an amblyopia in the deviated eye. So this is what the interpretation would be for the fixation. So strong fixation alternating. If the deviation, then think of an underlying amblyopia or some fundus pathology. Right. Coming to the measurement of ocular deviation, which is very, very, very important in a strabismus examination, there are two tests. One is a light reflex test and the other is a cover test. In the right reflex, we have three tests: the Hirschberg's test, the Krimsky's, and the Bruckner's. So this is a Hirschberg's. You throw a light 14 inches away and look for the reflex. You can see very well here. This reflex is centered, and this is an alternating esotropia. This reflex is in the pupillary margin. And this, based on this, you can say if it is in the pupillary margin, it's 15 degrees. If it is in the edge of the cornea, it's 30 degrees. Above that, it's 45. So that also give you an idea of the angle of deviation. So this is the Hirschberg's corneal right reflex test, and looking at the time, and the Bruckner's test. Again, this in our population might be a little difficult, but in Western countries, because of the lighter iris, you can then altered red reflex will give you an idea. See, altered red reflex, there is a cataract here. So it could be a tumor, it could be a strabismus, it could be an anisometropia or some retinal pathology. So that is one thing. And then the Krimsky's test is a prism reflex test or a prism reflection test, where you use the prisms to move the corneal reflection, the deviating eye. So this boy is a modified Krimsky's test. Suppose the eye is very densely amblyopic, that you cannot fix a target. So you put the target, the prisms of increasing strength over the normal eye and try to get the pupillary reflex in center. So this is the angle of deviation. So this is the modified Krimsky's test. When one eye is densely amblyopic or with poor vision or a sensory deviation, so this would be an ideal way to test the angle of deviation. Then cover test, you have three types of cover tests: the cover, uncover, the alternate cover test, and the prism bar cover test, which is helpful to measure the prism in diopters. So for a good cover test, you need certain prerequisites. One is a full optical correction, and then you maintain the distance, keep the head in primary position, choose the ideal fixation target. And for children, you choose a doll or something. For adults, you choose something else. And proper prism placement, proper occlusion, and very importantly, you need the attention and cooperation of the patient. So this is a cover, uncover test, mainly to differentiate. This is a child with the intermittent exotropia. You can see very well that, see, she's deviating. So the cover, uncover test will help you to differentiate between a phoria and a tropia. You have to break the fusion. So you see now, it gets the fusion broken and she deviates. So this is the cover, uncover test. Then second is the alternate cover test. It measures both the manifest and the latent deviation. So you dissociate the eyes for maximum deviation and then you do the measurement of the prisms. So this is the alternate cover test and this is the prism cover test. So this will give you the diopters of prism, how much you need. So you place the prism, I have to, one more, okay. So this is how you can see the child, placing the prism on the normal eye, and then this is how you hold it. I'm just showing the prism, the diopters. Loose prisms are more comfortable. So this is how you, and never stack two horizontal prisms. You can stack one horizontal and one vertical. So that is one thing you should keep in mind. So I'm not for want of time. And then simultaneous prism cover test. And this is how the prism cover test values will be depicted. And then this is prism adaptation test. When you're not very sure about this, you can do a prism adaptation where you can put Fresnel prisms to get the right amount of deviation, especially when the patient is very cosmetically, if she's very particular, then this is important. Then pattern deviation, always look for oblique muscle dysfunction. You can see inferior oblique deviation, overaction here for A and a V pattern. This is a boy with a V pattern deviation, because all this will help in good results, post-surgically. And movements, you have the bilateral movements, versions or conjugate, the uniocular ductions, and the distrugate versions. Again, I'm not going to the details. Cycloplegic refraction fundus examination is a must. And it is not complete with the cycloplegic refraction fundus evaluation. And always treat the amblyopia. Sensory tests, it is always better to have all these tests done. I'm not going to the details. Stereopsis. Then special tests, especially in restrictive strabismus or 2, I may take just 20 seconds more. Force duction test, especially, when there is a muscle palsy, you want to rule out restriction, whether it is paralytic or restrictive. This will be a good test. A force duction test can be done in the office. You make the patient lie down and then try to pull and see if there is a restrictive pathology. Then the fourth generation test, another test where even in the palsied muscle, if there is some amount of function in the muscle. So if there is a fourth generation test is positive, then you would go and operate on that muscle. So that is fourth generation test. Saccadic velocities, again, to find out the muscle function. If there is a float, then it is not good. If there is a movement, especially in sixth nerve palsy, then you can, tackle with that muscle. So this, for conclusion, strabismus evaluation is not a very complicated procedure, but learn it methodically and keep all the tips which I spoke in mind. With practice, anybody can get better and very less investment. And I would recommend students here to take up pediatric ophthalmology, because in India, that is the population which is going to go up. So thank you for the opportunity.
Thank you, Kalpana. That was a wonderful talk on a very big subject. And I am trying to make that non-existent soon. Thank you very much.
So I think we can have you next speaking.
Okay. Thank you. No problem. Thank you, Kalpana.
So you're going to speak on concepts of amblyopia management. Dr. Santan Gopal. No, there's no space.
There is no space.
Be careful, sir. Yeah. Amma, it's on the tip where...
Before I start my talk, don't start the timing till I tell you to start. I'm just joking. Now, you can start the timing. Start the timing, I'm just joking. My talk, Santan Gopal, must be loaded there. Did you get it? No, not that one. Nahi yaar, squint, Santan Gopal. They deliberately did something wrong. There, amblyopia. Okay, how many of you are postgraduates here? Okay, a lot of them. Please take the QR code from the boy there. He will give you, and copy that onto your QR code and get it on your email. All the details you will get about this instrument I am going to talk about. See, amblyopia, everybody knows, is loss of vision of two lines in one eye compared to the other eye. That definition has been going on for a long time. And we are amblyopic to what exactly has been the progress. Because we are happy, somebody has defined, we will continue doing the same thing. Why bother about worrying about it? Now, old definition is difference of two lines. Is it really the amblyopia? Amblyopia is associated with a number of other defects, like the contour interaction is wrong, the counting difficulties are there, hyperacuity difficulties, so many difficulties are there. And if you just say amblyopia is associated with difference of two lines between the two eyes, it has no meaning at all. So we need to change the definition of amblyopia. Now, how do you change the definition of amblyopia? You need to know the etiology of amblyopia. And you need to know where is the problem in amblyopia, then only we change the definition. There are basically four types of amblyopia: strabismic amblyopia, anisometropic, high ametropic and visual deprivation amblyopia, and hyperacuity disorder, shape perception, spatial interaction, and contour integration, visual counting, reduced or absent stereopsis, and motion processing. All these features are abnormal in amblyopia. How do you explain them? Just saying two visual line difference between the two eyes has no meaning at all. So we need to explain all these things properly in amblyopia. To do that, you need to know neuroanatomy, neurophysiology, neuropathology, and also you need to have all the other ophthalmic skills, not just this knowing neuroanatomy, etc. Okay, sorry, it went. Okay, vision is a very complex process. It has got dichotomous process, nasal and temporal retina, right and left eye. Then at the lateral geniculate body, you have the vision going into, oh yeah, something wrong. Okay, I'll keep my finger on that downward arrow. There's no light here. So at the lateral geniculate body, you see the central retina has a greater representation in 3, 4, 5, 6, whereas peripheral retina has a smaller representation in only layers 1 and 2. Again, there is a crossing of nasal and temporal. Nasal crosses, temporal doesn't cross. So these are all dichotomous processes which happen in the brain for vision. Now, if it didn't happen, then we would not have had binocular single vision at all. Now, in the brain, again, it's so complex that you need to time to understand and read. That is what the QR code will tell you in detail. That I asked somebody, where are you from? She said, I'm from Hyderabad. Okay, where exactly in Hyderabad? Well, which city, which street, which house number, etc. So in the brain, if you say amblyopia is associated with problem in V1, okay, where in V1? Is it associated? V1 has 6 layers, 1, 2, 3, 4, 5, 6. Again, layer 4 has 3 layers, layer 4A, 4B, 4C. Again, 4C has 2 layers, 4C alpha, 4C beta. Now tell me, where is the problem in amblyopia? The moment you ask that, everybody gets completely and thoroughly confused and they keep quiet. They don't ask me any question beyond that. So I am also happy not answering many questions because I myself am amblyopic towards a lot of things in amblyopia. Okay, LGB is not a simple relay station. Why am I telling you all these things? You stop me exactly. I don't have the timing. I can't even see the timing here. You stop me when I'm 15 minutes or 16 minutes because I started 1 minute late. Why am I telling you all these things? Because the machine I'm going to show you is going to make a lot of difference to treatment of amblyopia, and it is no longer patching. I don't patch any of my patients for amblyopia treatment of any type. Okay, in the lateral genital body, it goes to the layer 4C beta and 4C alpha. P cells go to 4C beta and M cells go to 4C alpha. That is the dichotomy in the vision which I am trying to point out. Okay, again, once it reaches the brain, every object has 4, 5 or 6 features: shape, size, surface, texture, color. Position, movement. An object may be moving towards you or object may be moving away from you. An object may be of particular color, texture, shape, size, etc. And these two are again separated into 2 different parts. Position and position and movement are by the supraparietal area, whereas the shape, size, texture, color, etc. is by the inferotemporal cortex. You see the dichotomy, how the vision, this is, see, if God had decided like the traffic condition in all over India, your brain would never have worked. And he has regulated it so beautifully that everything works properly even if they don't have brain. Okay, so let's move on to the next one. 6 layers, I have already told you. Layer 4 has ABC and C has again alpha and C beta. In alpha goes the movement and position of the object, and beta goes the other layer, other aspects of the subject. Now, right and left eye are segregated again in layer 4C, alpha and beta. The right and left eye are completely segregated. The right eye doesn't know what the left eye is doing unless the brain intervenes. You understand? They go ultimately to the binocular single cells situated in level 4A, 4B, and 4C. Till then, they are uniocular. Above that and below that, they are binocular. Okay, that is important to remember. And without the binocularity, you will not be very successful. Okay, let's not go to that. This is how the brain connection with the eye looks like. This is called Sarvendriyanam Nayanam Pradhanam. This is what they said 4,000-5,000 years ago. Now, why did they say that? Do they have brain? Well, they had brain, and you can see here how the brain from the eye is interconnected in various parts of the brain. And to realize that if of all the afferent impulses, 40% are from the eye. Afferent impulses that go to the brain, 40% are from the two eyes. And from the rest of the body goes the remaining 60% of the impulses. So therefore, eye gives you a lot of information about the brain of a person if he has, and about the abnormalities of the brain of the person also. Because you can diagnose psychiatric disorders also by looking at some psychiatric abnormalities. If there are some psychiatric abnormalities, you know that there is some psychiatric problem with the patient. Okay, tumors and all you can easily diagnose. So now, bold scan shows that in amblyopia there can be some problem with the blood supply of the area when the eye is looking at the object it has amblyopia. Okay, that side of the brain is not working or is working less. So even PET scan does the same thing. So one small eye, you can see how it can cause vast changes in the brain if it does not send impulses to the brain properly. Is eye subservient to the brain or brain subservient to the eye? Both are equally important. That is why we do not differentiate between eye and brain. We call it as retinocerebral apparatus. We are together, they are together. Retinal is not necessarily separate from the brain. And brain cannot function without the eye to an extent. But eye cannot function at all without the brain to any extent. But brain can function and compensate for the loss of the eye in the very early age by diverting information from the eyes towards the ears and other sensory organs. And it happens, I've seen so many children who are completely blind, but they can easily walk around because they do the echo as the, tell me when I'm, don't hesitate, please tell me if I'm, how many more minutes there? 5 minutes over there. Okay, so eye can have significant effect on the brain. In the same way, brain can affect the eyes also, okay, which you have seen. So for a complicated problem like amblyopia, we have been saying, oh, patch the eye. That's it, nothing needs to be done. Do you think it is correct? Do you think shouldn't we utilize all the other knowledge that we have obtained from cutting edge technology like FMR, bold scan, etc., DTI scan, MRI, different varieties of scans, etc., to find out where is the problem in amblyopia and treat it properly? By patching one eye, you are assuming that the amblyopic eye will focus. Not necessarily. It need not focus because the eye is controlled by the brain. In the brain, the eye is controlled by the attention center in the parietal lobe. So the problem in amblyopia is in the parietal lobe. Everybody will be shocked if I say the problem in parietal lobe and frontal lobe in amblyopia, then they will say, what is he talking about? For that, you need to read the QR code, and in that, everything I have explained. Okay, so to prevent and treat amblyopia, we have devised a new technique called orthoptic. He will show you the machine also. Sorry, where did it go? Yes, he will show you the machine also after the lecture. And what it does is, it stimulates the peripheral retina first. When you stimulate the peripheral retina, the information goes to the parietal cortex first. Even before the central P cells send impulses to the 4C beta. the 4C alpha would have already sent the information about peripheral retina to the attention center. So the attention center is grabbed first by the peripheral retina. But then the central retina grabs the attention center a little bit later, because it has to go to inferior temporal cortex and then come back to parietal cortex. So there is a gap of a few. Don't think that it takes ages. It takes only a few milliseconds gap that is good enough for the brain to understand. So the brain knows exactly where the eye should see, even before the eye has seen. This is what I'm saying. Eye has not seen the object and analyzed, but the peripheral retina has already seen and it knows where it is. So it tells the central retina, move the eye to see that fellow. And when eye moves, when the eye makes a saccadic movement, the retinal suppression happens in between the fovea and the peripheral retina. That area is suppressed. That means 2 points are stimulated in the brain: the peripheral retinal point, which we have stimulated, and the foveal point, which needs to be stimulated. Because as the eye moves to take a fixation, the fovea comes into fixation, it gets stimulated. So this is the principle on which we have based the machine. This machine treats amblyopia in majority of the children in less than 15 days. Younger children, 4 or 5 years old children, if you use it in amblyopia, in 4 days the amblyopia disappears. Whereas up to 55 I have treated amblyopia and it does respond. So what about the plasticity, somebody asked. There is nothing called plasticity in this particular thing, because it depends on what is called as top-down impulses coming down from the parietal lobe to the occipital lobe. Every time the eye moves to take a fixation, the top-down impulses come from the parietal lobe to the occipital lobe. Occipital lobe is a simple forwarding center. It just obeys the orders of the higher center. I call occipital lobe as Manmohan Singh. He doesn't do anything. He just follows two leaders who are there at the top. Whatever they say sit down, he will sit down. Stand up, he will stand up. But he is important because he has to transmit those orders forwards to the infratemporal cortex and the parietal cortex. So I call occipital cortex as the Manmohan Singh, infratemporal cortex as the Sonia Gandhi, and supraparietal cortex as Rahul Gandhi. So with this, I stop my talk. I think I'm almost through. You can collect the QR code and copy it. You will get all the information there about the machine, how to buy the machine. And in Delhi, we have Center for Sight, present President Harvansh Lal and Sudhang Bharti have bought, and many places in India, over 85 machines have sold. If anybody interested, he will show you the machine also. Thank you very much.
Uh, Thank you so much, sir. It's really difficult, my brain, to take all this. Probably all the postgraduates can absorb it very easily. Thank you so much. We have a small change in the schedule. So we'll have Dr. Devang Angmo for the gonioscopy and UBM for angle evaluation. And then we have Dr. Manodip Singh as the next speaker. Dr. Devang. Which one, sir?
A very good afternoon to everyone. कौन सा दबाना है? लेजर के लिए कौन सा दबाना है? पीछे, ठीक है. ओके ना. स्क्रीन शेयर वो कर दो. स्क्रीन इस पे हो गया. Done. I would be speaking on angle evaluation, which includes gonioscopy, AIOCT, and UBM. So if you look into angle evaluation, it has both subjective assessment, which includes gonioscopy, and objective assessment as in AIOCT and UBM. So if you coming on to gonioscopy, it is the current gold standard, although there are inter-observer variability, and there are different lenses also. So if you gonioscopy is basically a clinical technique which is used to examine the structures of the anterior chamber angle, and Trantas used the limbal indentation technique in an eye with keratoglobus, and he first visualized the anterior chamber angle in a live human being. And the term gonio gonioscopy was coined by him. Gonios meaning the angle and scopy means to visualize. So if you look into the principle, the normal angle of the eye is not visible due to total internal reflection. Okay, so that is why we need a gonioscope or a gonio mirror to cut this angle of refraction. And depending on the type of gonioscope that we are using, we have the direct and the indirect technique. So in the direct gonioscope, as the name suggests, there is a gonio lens that is sitting there, and you can visualize the angle that you are seeing. So if you are visualizing the superior angle, you will see the superior angle. Versus the indirect gonioscope, which is using a mirror. So if you're seeing the superior angle, it will show you the inferior, because the mirror will reflect the opposite angle. So there are different types of gonioscope. The most commonly is the KP's gonio lens, and depending on the size of the eye, we have different sizes. We have the Barkans, and lately the Swan-Jacob gonioscope is into vogue because now a lot of angle surgeries are being done. So this is a small video clip wherein we are putting a coupling agent, and then as in we put the lens. This is the case of primary congenital glaucoma. We can see the high anterior insertion along with few iris processes, and you can see a goniotomy being done. So in indirect gonioscopes, the most common is the Goldman single and double mirror. And for residents, I think you should invest in the Goldman double mirror to start with. Then we have the Goldman 3 mirror, which has 3 lenses for various, not only for the angle, but also for the mid-periphery and the equator. So this is the thumb rule, which you can memorize. Then we have the Zeiss 4 mirror. Again, it will have 4 mirrors to visualize. So indirect technique, that is the normal gonioscopy that we are doing, like with a Goldman mirror. So after putting a coupling agent and explaining the patient, anesthetizing the eye, we put in the gonioscope, and we have to make a thin slit beam. So the most important thing is that it is this gonioscopy is like a semi-dark room procedure. It should be done in a dimly lit room, because any kind of flashlight or any wide light will cause the pupil to constrict and will falsely open the angles. So the use of direct gonioscope, as I've shown, is a more panoramic view, and it will directly show the angle that you're viewing during surgery. So in all these angle-based surgeries, we are using the direct gonioscopes versus the indirect gonioscopes that we are using on the OPD basis for the clinical diagnosis of open and closed angle glaucoma. So next, they'll always ask you what are the indications of gonioscopy. So 2 things you have to remember. There is a diagnostic indication and a therapeutic indication. So diagnostic, the most important thing after doing gonioscopy, we want to know whether the angle is closed or open. And once it is closed, we want to classify whether it's angle, in PSCD, whether it's suspect or EPAC or a PSCD, to identify plateau iris, to identify secondary causes of abnormal angle pigmentation, pseudo exfoliation, angle recession, and also cases wherein our trabeculectomy has failed, to know the cause of failure to see glaucoma drainage devices, and also in congenital glaucomas. So in therapeutic, we are mainly using for laser trabeculoplasties. We are using for all the angle-based surgeries like goniotomy, gonioplasty, trabectome. For reopening of the blocked ostium, you first have to use the gonioscope, see where it is blockage. For indentation gonioscopy, to break an attack of angle closure glaucoma. So as I've shown you, the first thing that we do, we make a slit beam. And after making the slit beam, we have to make a corneal wedge. So first thing, you should look at the corneal wedge. So what is corneal wedge? Corneal wedge is actually, you can see there are two rays of light that are converging at the end. So these 2 rays of light, one is from the posterior surface of the cornea and one is from the anterior surface of the cornea, and they converge at the corneoscleral junction. And the corneoscleral junction is the mark of the Schwalbe's line, which is a marking of the anterior border of the trabecular meshwork, which is non-pigmented. So we don't see that part. We usually can see the pigmented part of the trabecular meshwork. So this landmark is very important. Depending on this landmark, we follow this landmark, and we will differentiate whether it's open or closed. So corneal wedge is therefore useful technique to identify the trabecular meshwork. So it is helpful, especially in cases wherein there are post-inflammatory, increased pigmentation. Like in this, the wedge is forming somewhere here, okay, and you can see that the pigmentation is more anterior to it. And also in very pale angles where there are hypopigmented angles, there you can see that the wedge is being here, and you can see the rest of the iris and structures are low below it. So next structure that you should know is about ciliary body band. So if you look into the gonioscopy, when we are doing gonioscopy, we are going from the anterior to the posterior. So the first thing is the root of the iris that you can see. Then you can see the ciliary body band, which is basically between brownish, dark brownish in our population. And this ciliary body band is actually the result of insertion of the iris into the ciliary body. And physiologically, what you should know is that physiologically wider, it is wider in cases of myopes and narrower in cases of hyperopes. Next, after the ciliary body, we have the scleral spur. So what is scleral spur? It is basically this prominent white line that you can see between the brown ciliary body band and the pigmented part of trabecular meshwork. This is actually the posterior lip of the scleral sulcus, which is attached to the ciliary body posteriorly, and the cornea scleral meshwork anteriorly. Then we have the trabecular meshwork, which has again in two parts. One is the pigmented part like this, and what's anterior to it is the non-pigmented part. So the pigmented part is important for us because it's the functional part. It is the primary site of the aqueous outflow. And the anterior non-pigmented part is anterior to it. And lastly, the Schwalbe's line, which is basically a junction between the anterior chamber angle structures and cornea where the Descemet's membrane terminate. And it is again the landmark for trabecular meshwork in narrower angles. So this is like a heavily pigmented Sampoli's line, which is basically a heavily pigmented pigmentation where you can see, which is much anterior to the Schwalbe's line. Then you can see a very prominent Schwalbe's line, and which is anteriorly also displaced, like in posterior ambryotoxon in cases of Axenfeld rigor. Then apart from the angle, you also have to look at the iris, whether the iris contour is concave, like seen in shallow AC, or it is convex, like in cases of deep AC or pigment dispersion, or abnormal peripheral thick roll, like in cases of plateau iris. And apart from that, one should know what is the difference between the iris process and a peripheral anterior synechiae. So if you look at these iris processes, these are filiform, fine filiform finger-like projections that follow the contour of the angle recess. When you magnify it, you can see that they are following the curve, versus the peripheral anterior synechiae, which are broad-based, thick beam-like structures, and you cannot see the structures beyond this pass. Also, you should know what is an abnormal neovascularization, which is important to diagnose neovascular glaucoma at a very early stage and management at an early stage. So these neovascularized vessels are fine, arborizing, and they cross the scleral spur. So apart from this, you should also know what is manipulative gonioscopy. So it is a special maneuver to see beyond steep irises. So one just asks the patients to look down or look up, look into direction of the mirror. So that way you can see the part of the angle which is not visible in the primary position. And one more important is indentation gonioscopy. So for this, you need a 4-mirror gonioscope, which has a small contact diameter. So it is important to, indentation is important to know whether it's an appositional or it is a synechial closure. And when iris covers the trabecular meshwork, it is very easy to mistake the non-pigmented trabecular meshwork for scleral spur. So when you indent it, the entire angle will open and you will come to know the structures that are seen. So this is how the gonio lens is put, and just a gentle, you have to gently press it, and you can see that once the angle opens, you can see these broad-based peripheral anterior synechiae, suggesting that this is a synechial closure. Also, it is helpful in to diagnose these plateau iris cases where you can see the sine wave pattern. One should know about occludable angles. So occludable angle is defined as one in which the posterior pigmented trabecular meshwork is not visible in more than 180 degrees of angle in primary position without any indentation or manipulation. So this is how it is. This is more likely to be an occludable angle versus this angle, which is totally open. You can see all the structures of the angle here. So once you do the gonioscopy, what should one ask? So once you do the gonioscopy, you have to see whether the angle is open or not. So if you can see the scleral spur, yes, the angle is open. If you cannot see it, then you have to ask whether it's a synechial closure or an appositional closure. So if we do an indentation, you'll come to know there's a synechial, it's a synechial closure. If there is no synechial, then you have to see whether the IOP is raised or not. If the IOP is raised, then it is a PAC of appositional type, and if the IOP is also not raised, then it is a PACS. And you have to document all your findings into a goniogram, which is important not only for medical legal considerations but also for follow-up how the disease is progressing. There are various grading systems which can be taken from any of the standard textbooks. One should follow one of the systems and not confuse with all these systems that are there. So these are just case examples wherein we can see a very heavily pigmented angles, both superior and inferior in cases of pigmentary glaucoma, especially the inferior angle is severely pigmented. Then you can see blood in angle. You can see the wide, you can see here the ciliary body band is very wide. So it's a case of angle recession glaucoma. In iridodialysis, normally you can see the root of the iris getting separated from the iris. In cyclodialysis, you can see a cleft there, which is basically the detachment of the ciliary body band from the insertion. Then in cases where you have the trabeculectomy has failed, you have to do a gonioscopy and see where is the pathology, whether it's the ostium that is closed or actually the iris is going and plugging and not allowing the ostium to function. Then you can use it for various diagnoses, like in cases of ICE syndrome, you can see that there is a posterior amaurotoxin along with the corneo-iridic adhesions. Emulsified oil in the sulcus many a times are missed because they are very fine globules. Iris melanomas, iris nevuses also. So what important thing that all of you should know, that being a contact procedure, it has to be sterilized and disinfected after every use. The second part of my talk is on ASOCT. So ASOCT has a lot of uses, but focusing only on the anterior segment and angle analysis. So for anterior segment analysis, it can be used both qualitatively and quantitatively. The most important thing for us is to identify the scleral spur. This is the most important landmark, which is seen as a bump in the inner wall of the sclera. Once we mark this scleral spur, the software, the computer itself has a software which automatically calculates all the angle parameters, AOD, 700, TISA, everything. These are built-in tools. So there are these quantitative parameters that one can use for various tools. And one more important thing is the ITC index, which is a quantitative measure of the extent of the angle closure across 360 degrees of the angle, and it expressed as percentage. So if you look at this angle, you can clearly see that is a closure, and the ITC index is 94%, meaning that there is a 94% closure, there's a 94% contact. So these are various pre and post phaco outcomes of the ITC, wherein initially it was nearly 98%, it has improved to 74%. So, and qualitatively, if we see that, you can also see whether the angle is open, it is narrow, or it is this is open, narrow, and totally closed. And these are high definition images of the angle, where you can see actual structures of the angle that are filtering. So this is one study from our center where we had taken cases of primary congenital glaucoma versus adult glaucomas, and we had seen that in cases of primary congenital glaucomas, there are actually membranes there which is covering the trabecular meshwork. So you also have a 360-degree view in this. And
Doctor,
this is
can
all
you summarize,
non-contact.
please? We are time up.
Okay. So, so this is about ASOCT. So just coming on to UBM. So at the end, I just want to say that ASOCT is a non-contact, 90-degree patient setup and a precise scanning location versus UBM, which is a contact procedure. So this is how the machine looks like. There's a computer setup. This is the probe. And after anesthetizing the patient has to lie supine. You have these cups, you have to put the fluid into it, and then you use these probes, which are 25 megahertz and 50 megahertz. For angle visualization, we are using 50 megahertz, and only a quadrant of the angle is seen. You can't see the 360-degree angles in this. So it only visualizes one part of the angle. What is the most advantage of this is that visualization of structures posterior to iris pigment epithelium, including serially body, can be done, which cannot be done with that of ASOCT. Again, similar to ASOCT, it has qualitative and quantitative estimation, and there are various examples. So the most importantly, like
Whatever
ciliary
you
body
want.
cysts and iris
Well called,
cysts
sir.
are usually visualized with
I have
this,
one comment
and ciliary
to
body
make.
tumors also.
Here.
And at the end, I would like to say that imaging the anterior chamber angle is germane in understanding the angle anatomy and pathophysiology of various glaucomas. Gonioscopy is the gold standard. ASOCT being non-contact and a very rapid procedure, it enhances the visualization of angle structures, provides 360-degree visualization of angles also. UBM is again a contact procedure, but used for structures to visualize structures posterior to iris pigment epithelium, including the ciliary body. And I think at the end, I would like to say that multimodal imaging is useful in decision making in complex anterior segment cases.
Thank you.
Thank you for the patient listening.
Thank you, Dr. Devang. I'm sorry we have no time for the discussion for any of these topics here. So I would request.
Manavdeep, you can start. Before you start, by the time you make arrangements to go there, I have one small question. Why don't you promote the RPC grading first and delete the rest of the grading? Make in India is our motto. We are much better than any Western country. Please get that into your brain as quickly as possible. It helps. We are no inferior to any country in the world.
Devang, can you just move out so that he can prepare?
So next time onwards, put RPC grading first, please.
The next speaker is Dr. Manavdeep Singh. He is going to talk to us on the intraocular pressure measurement and the concept of target IOP. He has won the video on this particular topic on the intraocular pressure measurement. And I'm sure that Dr. Manavdeep is going to show that interesting video on if you have one of that.
Thank you for those kind words, Satyan. The full video people can see on the YouTube. It's
YouTube.
a 14 minutes video, can't be shown here. I'll be
Okay.
showing only a part of it. Should I start?
Yeah, please.
So intraocular pressure is the only modifiable risk factor in glaucoma, all of you know, and therefore importance of accurate assessment of this cannot be, overemphasized. So the interpretation of this, normal is called 10 to 21. However, there is no hard and fast rule. If a person has a normal of 10, goes to 15, it's certainly glaucoma. It should be viewed in the light of central corneal thickness because falsely low readings are seen in thin corneas. Asymmetry is most important. One eye has 12, other eye has 16. Both are in the normal range, but 16 is possibly may have glaucoma. Diurnal variation again can be an initial sign of glaucoma. Amount of fall with drugs is another importance of glaucoma. We must know whether it falls with the treatment, whether the treatment is effective or not. So the principles are known to all: indentation and applanation. The new principles are contour matching and rebound. So this is what, if you want, you can click a picture of this, and this is my video of what Dr. Satyan was talking. It has got the maximum views on this topic world over, around 1.5 lakh plus views here. So this is the gold standard instrument which has got 5 parts, and this is how it looks like. I'm sure all of you must have seen. The most important thing I would like to see, this is how it looks inside. The principle is Imbert fixed law, but this law applies to the surface which are perfectly spherical, dry, flexible, elastic and infinitely thin, which eye is not. So it requires modification. So for that we have a specific size of the prism that makes us, help us in able to find out this. This is running automatically. The applator tip is, the probe tip consists of doubling prism which is used to ablate cornea, and it optically splits the circular area of tear film contact into 2 semicircles by inducing horizontal shift. So this is this size is in a way that the errors of that Imbert fixed law they are removed because the size is 3.06 millimeter diameter. So this is how the correct alignment is. The 2 semicircles should interlock with equal size and width of the mire should be around 1/10 of the diameter. So these are the problems that can happen in these mires, and we should look them in the view of centration, thickness of the fluorescein ring, application force. If the rings are thick, then you need to wipe the patient's eye, and in case they are thin, you need to add some more fluorescein. So this is a small video which I'll be showing. It's a part of the main 14 minutes video.
Despite all these novel modifications of the principle of applanation, introduced in 1954, GAT still remains the gold standard instrument to measure IOP for the management of glaucoma. The probe consists of a doubling biprism which is used to applanate cornea, and it optically splits the circular area of corneal contact into two horizontal semicircles by inducing horizontal shift. On touch, tear film appears as a bright yellow-green spot which turns into semicircular arcs when the tonometer is moved forwards. When 3.06 mm diameter of cornea is applanated, the semicircles interlock. The thickness of these semicircles represents tear meniscus on the sides of prism. The equipment preparation includes setting the magnification at 10x, switching power to maximum illumination, maximum thickness and maximum height, bringing the blue filter in place, and creating an angle of 60 degrees between illumination and microscope. Prism and tonometer should get fixed into notch. After this, turn the measuring drum to setting 1, which is equivalent to 10 mm of mercury. Now, the patient preparation. After informing the patient about procedure, anesthetize both eyes with proparacaine. Place moistened fluorescein strip in lower conjunctival sac and place head of the patient on chin rest. Fluorescence of the stained tears facilitates visualization of tear meniscus at the margin of contact between cornea and the biprism. Now, I would brief the procedure for actual measurement. After obtaining contact, observe cornea through microscope. Regular pulsations of two exact semicircular rings or equal size show that tonometer is in correct position. These pulsations represent cardiac cycles. Drum is rotated to adjust pressure on globe until the internal edges of both semicircles meet at midpoint of these pulsations. Reading is multiplied by 10. Inaccurate vertical alignment can give rise to false IOP values. This part of video shows inaccurate vertical alignment which is being corrected. Inaccurate horizontal alignment means that IOP which is being recorded is different from actual intraocular pressure in the eye. Small semicircles away from each other suggest IOP is higher than shown by the drum position, and large overlapping semicircles suggest drum reading is higher than actual intraocular pressure. When accurate IOP reading on drum is reached, the rings are exact semicircles of equal size, vertically well aligned and horizontally interlocked at internal edges. It is essential to emphasize that thickness of mires should be around 1/10 of the total diameter of flattened area. Prolonged contact of prism with cornea can lead to corneal injury and reduction of IOP, and hence should be avoided. Now, the calibration check. Although the manufacturers recommend once a month calibration check of the instrument, general consensus is that 3 to 6 monthly check, depending on the age of the instrument, is sufficient. Calibration check is performed at scale readings of 0, 2 and 6. Precise setting of mark is key to successful calibration check. If any defect is detected in the calibration, the instrument may need to be sent to manufacturer for repair. The technique of in-house calibration may be learned by going through another video by the same author. Despite all these novel modifications of the principle.
So pachymetry, I told you the importance of this. However, there can be certain errors. The thin corneas, they underestimate IOP, thick corneas overestimate, and astigmatism more than 3 diopters is significant because you have to press more to be able to applanate. Then distortion on irregular cornea influences the accuracy, so it cannot be. This instrument is not very accurate for that. So this is the same thing. You can take a picture if you missed it during the previous option that I gave, and this is the full video link. The other equipments are more commonly used. Non-contact tonometer, it's an air puff here, generates the applanation, computer calculates intraocular pressure and displays digitally. Advantages are user-friendly and no anesthesia, but it is not accurate, should not be used in glaucoma clinics. So then there can be some portable instruments which are more useful in OT and in children, and can be used in the OPD also. And tonopen is a portable handheld Mackey-Mark based tonometer, and it is used for irregular corneas because it is not based on optical system. The area of contact is small, and because it is not electronic dependent. Pneumatic tonometer again is based on Mackey-Mark principle and is used for diseased corneas and can be useful for continuous monitoring, and it's basically a research tool, least often used in the clinics. Do not confuse it with ear puff tonometer, which is another name for non-contact tonometer. Pascal dynamic contour tonometer. Actually, in fact, we know that all forms of tonometry currently available are affected by central corneal thickness, although the extent varies. So this DCT was designed to eliminate the influence of the corneal thickness and rigidity, especially for the post-keratorefractive surgery cases. It's especially useful for keratorefractive surgery, therefore, but it's expensive. It is running expenditure is there, and it takes a lot of time for this to use, so it has not become very popular. Ocular response analyzer. This is to remove the effect of biomechanical properties. There is a decline in the measured intraocular pressure following keratorefractive surgeries, even if there are no changes in the central corneal thickness. So this is because of the biomechanical changes, and two parameters of corneal viscoelasticity can be measured by ocular response analyzer output, and these are known as corneal hysteresis and corneal resistance factor. This is done by two applanations done, one while the air is pressing, and then once it is coming back to normal and it's getting applanated twice. The rebound tonometer, this is a handheld ballistic device. The probe hits central cornea and the microprocessor analyzes the deceleration of the probe following impact. It's easy to use, no anesthesia, so useful in children. Transpalpebral tonometers are basically handheld tonometers used by the patients at home. There are large number of other equipment which are useful, but cost is prohibitive and have their own limitations. So the goal of glaucoma management is to promote best possible well-being and quality of life with minimum glaucoma-induced visual disability within a sustainable healthcare system. This is European guidelines. So target pressure, this is the second part of my talk. Strategy to achieve the goal. This is decided to achieve this goal and to identify the patients with glaucoma and the risk of severe visual loss, to identify patients with the risk of developing glaucoma. Decreasing the risk of progression, this is most important, decreasing the risk of progression of disease to an extent which will avoid visual disability during the lifetime of the patient and will be sufficient to maintain quality of life. So which pressure can do that? That is our target pressure. There is no single target level which is appropriate for every patient, not even for every patient, but rather every eye. The target pressure is a dynamic entity and will be changed in case, suppose there is a progression going on at a particular pressure. Suppose you had made a target pressure of 16. So in case there is progression, you have to bring it down to 14. So it should be reevaluated during the assessment of the patient, during the follow-up of the patient. So this is a well-known graph, whom to treat, from European glaucoma guidelines. This is what the normal is, and this is what this line has been added by me, this F line. So we want the target pressure which will make parallel to this. This is where the disease is, because we have got this much of damage, and we want the ganglion cell loss to be parallel to the normal aging loss. So this is ideal, this is the ideal target pressure. So how to set the target IOP? So we need to see these 4 or 5 things: the amount of glaucomatous damage, life expectancy, untreated intraocular pressure, that means the baseline pressure, that additional risk factors, and rate of progression. And this you can go through the details from the European glaucoma guidelines. So consideration of target intraocular pressure, the likelihood of symptomatic visual loss is the thing that we have to assess, and this is dependent on, and we have to see the adverse consequences of intervention. the advanced initial glaucoma damage, the fast rate of progression, the long life expectancy, the additional risk factors. All these things, if present, they reduce the target IOP. So based on these things, we decide the target IOP, and then the status of the other eye is also, effective sometimes in taking the decision regarding the target IOP. And of course, the patient preferences, the timings, and all those things have to be taken care of. So adjustment of the intraocular pressure target IOP over a period of time, we determine the individualized target IOP and aim for target IOP. We prescribe the treatment accordingly and re-evaluate this. And once there is progression, we aim for the low target IOP. If it is stable, then we follow up again. Anytime there is a progression, we aim for a lower IOP. If it is stable and the target is reached, we re-evaluate it as and when required. And if it is not reached, then consider accepting higher IOP or re-evaluate or treat the patient accordingly. Thank you very much.
Thank you, Dr. Manavdeep Singh. Here,
Yes, sir.
I have only one small question.
Yes, sir.
Most glaucoma people keep saying pressure can be low, still be glaucomatous.
Yes, sir.
Okay.
Yes, sir.
And most of them say this vascular condition or this vascular condition can cause glaucoma, etc., etc.
Right, sir.
But ultimately, when they come to treatment, they will say we'll operate and lower the pressure, still lower. Because there is no alternative at the moment.
Yes,
There are many ways to skin the cat,
Yes, sir.
but not all are perfect.
Yes, sir.
There are different ways. So, do you see an end to all this and one treatment for glaucoma?
Sir, at the moment, the only thing that we have is reduce the intraocular pressure. The normal pressure patient can be normal, as I said. So the baseline pressure of an individual, sir, I have seen even theoretically it cannot be less than the episcleral pressure, and the episcleral pressure is 10. I have seen myself pressure of 10, 8 in normal people. So in case a person with 8 or 10 or 11 goes to 16, 17, he is definitely glaucoma. There's no
But it's
doubt
still
about it.
within the normal limit.
Still within normal limits. So that's one part of the story. The other part of the story is that the corneal thickness may not have been taken into consideration. And the third thing is that in West, why the incidence of normal tension glaucoma in West is much more than India? Because we do 24 hours diurnal variations. A lot of youngsters are sitting here, and many of them might have been forced to do 24 hours IOP and having sleepless nights. This is the benefit is to the patient. Patient gets something like normal tension glaucoma is then changed to primary open angle glaucoma diagnosis. They say up to 30% is normal tension glaucoma, which is not a fact in India. We don't have more than 10% NTG.
Correct.
And of course, there are rare cases in which there can be some vascular factors. Those cases are very, very uncommon.
Thank you. Next is Dr. Ronnie George, another glaucoma man. There are 3 glaucoma people here. I am a squint man. I should never talk to them and ask them questions.
Sir, I'll take 10 seconds to invite all of these people sitting here to the annual conference of Glaucoma Society of India, being the secretary. And this is to be held in Hyatt Regency, Pune from 6th to 8th October 2023. Next will be in Pondicherry, but this year it's in Pune.
Thank you. Ronnie George was trained by one of my close friends, Ravi Thomas, if I am correct.
You are very much correct, sir. You have met us at that time also. So, I'll speak to you about optic disc evaluation in glaucoma. And basically, the reason why it's important to look at the optic disc is because you must have heard this 10 times in this conference already, that optic disc changes can precede visual field changes. So the standard is to use a slit lamp microscopy because you need to use a binocular method of assessing the optic disc, which is a 3-dimensional structure. So use a 60, 78 or 90 diopter contact lens. If you have a dilated pupil, the 60 diopter is the best. If you have a small pupil, the 90 diopter is the best. The 78 is a good compromise between the two. And don't forget that the image that you see will be inverted when you take a look at it. So one of the disadvantages of the 90D is a limited magnification that you get with it. It's very simple to look at the disc. You just need to observe the 5 R's. The first is to observe the scleral ring to look at the limits or the size of the optic disc. The next is to identify the size and the shape of the rim. The third is to examine the retinal nerve fiber layer. And the fourth is to look at the region of peripapillary atrophy. And the fifth and the last one is to look for retinal and optic disc hemorrhages. So these are the 5 R's, and if you follow this, you can usually assess most discs accurately. So how do you identify the still rim? And what you do over here is you have to look at where the vessels bend. Look at the region of the vessel bending, and that is the edge of the rim. That's the edge of the cup. The still rim is this whitish, slightly elevated line that you will see all around. It's sometimes a little difficult to identify in myopes, but most of the times you can identify it fairly simply. Then what do? You can assess the optic disc. So, if you really are mathematically inclined, you can use a formula to look at the disc area. But most of us just would look at the vertical disc diameter, and that will give you an idea of the disc size. Don't forget that each of the lenses that is available to you has different magnification factors. And these are the magnification factors for the different lenses that you use. So if you're measuring on the slit lamp with the graticule and you get a measurement of 1.2, if you're using a VOC 66D, that's exactly what the vertical height is. If you're using a VOC 90D, you need to multiply that into 1.33, that's all. In general, we classify discs like this. A small disc is less than 1.5 millimeters, a medium disc is 1.5 to 2.5 millimeters in area, and a large disc is greater than 2.5 millimeters. And you can see that all three of these are normal discs, but see how the cup has changed in these three discs. So why does disc size matter? And the reason that disc size matters is that the number of retinal ganglion cells in an eye remains relatively constant. It's between 800,000 and 1.2 million. The optic disc size varies much, much more than this. And when we looked at our own data from the Chennai glaucoma study, this is the range of optic disc sizes by planimetry. You can see that most of the discs are in that middle range, 2.5 to 3 to 3.5. The mean disc areas range from 1.84 to 4.23. That is, the disc area more than doubles. And the mean vertical cup to disc ratio ranges from 0.2 to 0.54 in normal people. So your cup to disc ratio is very much dependent on your disc size, and that's why it's important that you should look at disc areas. These are two normal discs, and both of them look very different in terms of the cup. And this is because in a normal population, the disc size can vary by as much as 1:8 times. There is almost no other organ in the human body where you will see an 800% difference in size. You don't see people who are 1 meter tall and 8 meters tall. You don't see people with, axil lengths like that or any other feature like that. So that's one of the reasons why it becomes difficult to assess glaucoma sometimes. So we finished identifying the size of the rim. Now you look at the rim, and the rim you need to look at two things. You need to look at the contour and you need to look at the color. So the neuroretinal rim in glaucomatous damage, you look at contour and you look at color. And how do you assess the borders of the disc and the cups? You assess the borders of the disc there. Now you assess the borders of the cup by looking at each area where the vessel is bending. It's important that you look for that. Don't look at the white area in between and think that is a cup, because if you look at this disc, where do you think the cup is? Most of us would take a quick look, and especially if you're not paying attention, you would just put it there. But the actual cup is there because that's where the vessel is bending. And when you do that, you realize that there is some inferior thinning, and you can see that the edge of the vessel is right there. So that's why it's important that you look at the vessel and not the color. The next thing that you look at is how is this rim distributed? What's the pattern? And all of you are familiar with this. Is the AIOC rule. This is the normal, about 3/4 of this follow this pattern, that the inferior rim is thicker than the superior rim, which is thicker than the nasal, which is thicker than the temporal. And in general, no part of the optic disc will be thinner than the temporal rim. So you will not get even a local area which is thinner than the temporal rim. So what all can you see? So like this, you're seeing a disc. Here the inferior rim is a little thinner, but that thinning does not extend till the edge of the rim. Therefore, this is an incomplete notch. Conversely, in this eye, you have complete loss of the rim in the superior area, and that's a complete notch, which you will usually see with a defect coming close to fixation. Here you're seeing concentric thinning of the neuroretinal rim, and that's going all over there. Look at where the vessels are bending. And this you can typically get with it very high pressure glaucomas acutely or latent disease.
The other thing that you need to look for is cup to disc ratio asymmetry. So if you look here, you can see that in this eye, your cup is fairly large and this eye is fairly small. This sort of asymmetry is rare. Any cup to disc ratio asymmetry of more than 0.2 with similar disc sizes should be looked at much more carefully. How do you assess this symmetry? Quite easy actually. This is a pair of asymmetric discs. In fact, this is, any of these are glaucomatous? What do you think? It's a colleague's photo actually. He's also a glaucoma specialist. So it's his picture, and that's what the optic discs look like. You put them together, and when you look at the sides, you can see that the yellow is definitely larger than the green, and that's the reason that the cup is also looking larger. And it's actually, there's nothing wrong with it. A pale rim increases the likelihood of a non-glaucomatous optic neuropathy, and there's a separate talk on that, so I will not go into that. So the next structure you look at is the retinal nerve fiber layer, and this is where all of us become a little lazy because we don't feel like changing the little dial on top and putting on the red free. If you put on the red free, you can see it much better. You can see it even better if you take a red free picture. So what all do you need to do over here? You need to look at the brightness, the striations, whether you can see the peripapillary blood vessels, and whether there's diffuse or localized nerve fiber layer loss. So typically this is how your nerve fiber layer is distributed. You have a bright zone which is on top, then you have a dark zone which is next to the macula, and you have a bright zone. So it's bright, dark, bright. This is what you should expect to see in every eye. When you have a nerve fiber layer defect like over here, you're seeing a localized dark zone in a bright area. And this is easy to visualize. There's also a disc hemorrhage there. So this is a patient with the superior notch that I showed you before, and you can see that wide, dense RNFL defect. You can see how the blood vessels there are much better visible as opposed to any other area. And this is one of Yost-Jonas' rule, who says that every disc has an RNFL defect unless you prove it otherwise. Basically, it's telling you unless you have ruled it out, you cannot say there's no RNFL defect. So this is somebody with a subtle, more subtle defect. You can see that there is some difference in contrast between here and here, but this is again something that you will not see unless you look with a red free picture. Now you look for the areas of peripapillary atrophy. And why is the peripapillary atrophy important? It's important because of increased visibility of the choroidal vessels and sclera because of the atrophy of choriocapillaris, which can also be a sign of glaucoma. So the alpha zone is not that significant. It's a regular hypopigmentation of the RP. A progressive increase in the peripapillary atrophy can be a sign of increasing damage, like in this disc over here. So what you're seeing over here are the green arrows are the alpha zone, and the yellow arrows are the beta zone. So this is better differentiated. You can see that green arrows there, and you can see a localized inferior beta zone. If you look at the vessels carefully, you will see that there is thinning in this area too. So this is somebody who needs to be evaluated in detail for glaucoma. The next thing that you look for is the retinal and optic disc hemorrhages. And here when you look at what you need to realize is that they are not permanently there. They come and they go. They often disappear in 1 to 3 months. And this can indicate future glaucomatous progression, at least in Indian eyes. So this is an optic disc hemorrhage that you're typically seeing. It usually crosses the border like that. It's usually at the superior or inferior poles. At the nasal and temporal, it's unlikely to be glaucomatous. So here you have something which is just on the supratemporal pole. It's a resolving optic disc hemorrhage. So when you're looking at the 5 R's, scleral rim, RNFL, peripapillary atrophy, disc hemorrhage, the size, remember to measure the vertical diameter or describe it as small, medium, or large. Once you have done a few measurements, you will get used to doing it as small, medium, or large. The rim, is the Ising pattern followed? Is there localized thinning? Is there pallor? These are the 3 questions that you need to answer. RNFL, very simple, is there a defect or not? Peripapillary atrophy, is there peripapillary atrophy zone alpha or zone beta? And finally, an optic disc, this is just again a yes-no question. So if you cover these points, you can actually be fairly sure of having assessed your disc reasonably well. So how do you document this? You can write it, which is not a very efficient way of doing it. You can draw it, which is much better, and drawing it actually makes you focus on each part of the disc. Photographing is of course the best way, or you can use something like the DDLS scale, with which you can sort of classify the disc into each of these groups. This is available online without any problems. I never spoke to you about the vertical cup to disc ratio. No? That's what all of you are writing, all of us are writing. Why didn't we do it? Because it is most dependent on the optic disc size, so the vertical cup to disc ratio has really no value. And if I look at the same disc twice, I'm likely to have a difference of at least 0.1 plus or minus from my last reading. If I and you look at it twice, we might have a difference of 0.2. So it has very, very little value. The only value it has is if you measure the disc size and then you put on a vertical cup disc ratio and you mention what's happening with the rim, then perhaps. So what do you think about this disc? Glaucoma, not glaucoma? Show of hands. All those who think it's glaucoma? Okay, you are all right. Why? Because there's inferior thinning, and if there's an inferior nerve fiber layer defect, better visible on this. What about this? Is the disc small or is it medium or large? How many for medium? Okay. Okay. So on disc photographs, it's difficult to assess because it depends on what magnification you have used to take the photograph. But yeah, I agree with you, it's medium. So glaucoma, not glaucoma. Very good. All of you don't need the class. So it's a medium-sized disc with a large cup. The RNFL looks perfectly healthy. There's no localized thinning. What about this? Glaucoma. Very good. So this is a large disc, concentric thinning, both inferior and superior. But there's no nerve fiber loss. Why is that? Because when you have concentric thinning, you have uniform loss all around. So you're not seeing a localized effect. So this is something that you need to watch out. So just because you don't see an RNFL defect doesn't necessarily mean it's not there. So careful systematic assessment of all the discs by applying the 5 R's is really helpful in detecting early glaucomatous damage, and I hope the class helps. Thank you.
Thank you, Dr. Ronnie. That was a wonderful in-depth overview on optic disc evaluation. Are there any questions? So if Dr. Dilip Lalwani is available here, we move on to the next speaker, Dr. Satyan Parthasarthi. He's going to talk on glaucomatous visual fields interactive session.
Very good evening. Would you like to just stretch yourself? Already Ronnie has done it. Want to get up once and sit down? I think it still looks like everybody is asleep. Okay, I think concentrating for 2 hours on this is, for me, it is almost I slept off, and one more person to accompany me was the last person. So thanks so much for falling asleep. That means the teachers are good enough. So just to proceed with that, I am still going to take you for another 15 minutes to sleep. So the visual fields is area in which a person can see at a given moment. I am just seeing you without moving my eyes. That's the visual fields I have. Each eye has its own field of vision. The direction of fixation without head or eye movement. So I am just staring at you. This is how the visual fields is looked at. All of us know this man, the gentleman, the turquoise. So it's a hill of vision in the sea of darkness. What does it mean? You keep hearing this whenever you go to the glaucoma meetings. You keep on hearing this thing. So the hill of vision means the macula has the highest sensitivity. You show the lowest brightness, the macula can still pick it up. So that is the hill of vision. And as you go to the periphery of the retina, the sensitivity of the retina becomes lesser. You have to give a much more stronger or brighter stimulus for it to appreciate. So as it goes to the periphery, the hill becomes lower and lower and it becomes flatter. So macula being the top and then this comes down. All right. So the spatial extent, for me, I used to remember like this: 50, nasal is 60, bottom is 70, and this is the widest area, you have 90. 50, 60, 70, and 90. So don't have to really look at all this too much. Just simple remembrance. And when you have both eyes seeing together, then your field of vision is much wider. Okay, there is a interconnection between right and left eye, so you have a little wider area of the field. Then you have the sensitivity. We keep talking about this sensitivity whenever we are doing the visual fields. So there is a different kind of stimulus is being given. There's a different kind of a brightness is there. So the brightness is called as the sensitivity. So it is assessed in the decibel values. When you have the 0 decibel value, that means that is the brightest light. When you have a 32 or 40, that means it is the light, very dim light is being projected. So that's how it is. But normally you have between 30 to 35 is the range where most of us can appreciate. 40, I can't appreciate 40, maybe some people, but that's how the study shows that maximum sensitivity appreciation can be at 40. So whenever you are doing the visual fields, what are the things that you look for? One is you identify the pathology. Sometimes it may not be glaucoma, you are dealing with something else. Then you have the status of the disease. That means you are trying to say that, okay, the patient has early damage, moderate, severe, or advanced disease. So, and it helps in follow-up to see whether the patient has a stable disease or the disease is progressing. Then, once you start treating the patient, of course, we are going to see again the progression to understand whether the treatment efficacy is okay or not. Then, of course, it can be used for other purposes like visual ability testing. But at least in Tamil Nadu, what we have is the doctor, whoever is there, or even the driving license people, they just sign it saying that your visual field is okay. The patient never comes to you for any testing. So, looking at the glaucomatous field, so this is the fundus. Just try to understand how the nerve fiber layer arrangement is. That is where you have to see where the defect is. So this is the nerve fiber layer arrangement in a retina and the optic nerve, how it is getting into. More the peripheral nerves, it comes on the disc in the periphery. The more closer to the disc goes center of the disc. You can see the bottom here, in this bottom you can see that the periphery, 5, you see the 5 is in the periphery and you see the 1 in the center. So that's how the nerve fiber layer is arranged. So there are different parameters, examination parameters, and also of course you have other things that we need to just see that type of perimetry and what is the type of stimulus, test pattern strategy. Let's look at each one. When you're looking at the types of perimetry, you have the kinetic perimetry and the static perimetry. Most of us, we don't use the kinetic perimetry. Where do you really use the kinetic perimetry in your, I think most of your PGs, where do you use the kinetic perimetry in your hospital? Madam? Bedside evaluation, okay, there is a confrontation. Where do you really use the tangent screen? Somebody in the back? Tangent screen, where do you use? Where do you use the tangent screen? Usually, at least when we were studying, we used to use the tangent screen for neuro-ophthalmology fields. Okay, now I don't know how many of you are really using for the neuro-ophthalmology fields, but we can use the tangent screen for the neuro-ophthalmology field, but usually now it is all the static perimetry, which is much more easier to do and more reliable to do than the kinetic perimetry. Of course, we have the two important machines for the Oculus. Some of you may be having it and using it. Humphrey and Octopus are the ones which are in the market. So just to understand about the static and the kinetic perimetry, static perimetry's advantage is it is a kind of a gold standard and have a high precision in threshold values, assessing the threshold values, and it is fully automated. And the kinetic is just opposite to that, but it has a high spatial resolution and has a fast peripheral testing, provides information about the visual function. So these are some of the things that where it is used, both are used, but no more common for the kinetic is in the neuro-ophthalmology field, low vision, children, all those patients that we can use there. So next, looking at the stimulus or the spot size, we have different spot sizes to assess, but usually it is the spot size 3 at an angle of 0.43. That is a standard stimulus size. If you really look at the Humphreys or Octopus, all of them, they use it at the size 3. The other size which is commonly used is the size 5. Where the patient has a low vision, where he is not able to appreciate, then we use the size 5. I don't know why they have given all the sizes, but usually we use only the size 3 and the size 5 as a common ones. And you have the stimulus types. What are the stimulus types? You have a standard one, that is a white on white perimetry. Then you have flicker perimetry, pulsar swab, that is a function specific perimetry, where it is used for the early detection of glaucoma. The pulsar and flicker most commonly are used in the octopus perimetry. If you go to the stall in biomedics, you have the octopus perimetry 600. You can ask them to just show you. The swab is just been used again in both the the perimeters, octopus as well as the Humphreys. The short wavelength automated perimetry, that is a blue on yellow, the blue background with the yellow stimulus. So what has been deducted? White on white is a standard perimetry where you have the moderate to severe disease. That's really useful. If you really want to pick up like ocular hypertensives, glaucoma suspects and early glaucomas, possibly you can look at using the pulsar or the flicker perimetry or the swab. But swab really takes much longer time. The patient becomes really very tired. So there are certain test parameters are recommended. I'll just focus only on the glaucoma. There's something called as a G pattern. G pattern is one of the tests which is commonly used in octopus perimetry. And if you look at the Humphreys, we use either a 24-2 as a standard one. Sometimes we use a 30-2, but we have to avoid the peripheral points. But usually we all use only the standard 24-2 or the 24-2C program in the Humphreys now with the recent updates. So looking at the test strategy, but now with the advancements in the perimetry, I'm not sure how much we use it. But when you're using the Humphreys, earlier we used to use this 4-to-1 bracketing when you have a full threshold test, but we don't use anymore full threshold or even a G dynamic, we use it, but this is how it is done. Initially the 4 decibel lowering and 4 decibel incremental, and to assess how much the patient is able to appreciate, and 2 decibel lowering, 2 decibel incremental, same way the 1 decibel lowering and the incremental. That's how the bracketing is done, and that is how many number of points for 1, 2 and 4. That's how it is. So the standard pattern in glaucoma care is the G pattern. The G pattern in octopus just follows the nerve fiber layer arrangement. That's why the G pattern is very popular. And if you really look at the 24-2C pattern in the Humphreys, it is also just following it almost closer to that. So this is very significant. If you don't have it on the nerve fiber layer arrangement, then you may just pick up some defects. So that's why the Humphrey is also changing its patterns. And of course, there are other alternative patterns which how many test locations. You have 32, you have 32-2 with the 76 locations and the 24-2 with the 54 locations. But the 30 G pattern is 30 degrees with the 59 points are the ones which are tested. The central areas are also focused more so that we don't miss out anything. The papillary macular bundle area also is picked up very well. Then of course these are the other test patterns other than the G pattern. Macular function also we can look at, that is the 10-2 program. Even in early glaucomas we do the macular function or the 10-2 program so that we can pick up the early glaucomas. It's not like you would do it only in the advanced glaucomas. Sometimes you have the question on that. So this is how the octopus perimetry will look like, the 7-in-1 printout. I'll just discuss you a little later. And most of the time we keep talking about this age compared data. If you don't have the age compared data, then whatever you are seeing is not correct. So that's why when you are entering the age, make sure that the age has to be entered properly. Sometimes we have the confusion in either in the US or in the Europe. What they do is they put the month and then they put the date and then the year. So there is always some amount of confusion, but that doesn't matter. But the year has to be mentioned properly. The few months plus or minus doesn't matter, but then this is another thing which is very crucial called as a defect curve or the baby curve. Is one of the wonderful persons. The baby we have, I have met him in person. He is a scientist, physician. He is not a doctor. So what they really do is, this is, you see here, how it is drawn is, it is taken from the comparison. You have defects, lot of areas are defective. So the lowest defect, that is a plus, that is less than 5 decibel loss. It is presented here. and then slowly as it progresses, you have the highest loss. This is like more than 30 decibel loss, it is projected here. So it starts from left to right, this is the normal range. If it is like this, then you'll have to see how it is the defect curve is drawn. So this defect curve will give us a lot of information on whether it is normal, borderline or diffuse. And with that information, we can pick up what kind of a problem the patient has, whether the patient has a local defect or patient has a diffuse loss, everything can be taken up. So something called as a cluster analysis, how the cluster has been taken. So this is the cluster graph. You see what all the area, points are defective. If it is closer to the 10 degrees, then you have to start the treatment much more aggressive. And the follow-up patient shows more cluster damages, more closer to the macula, something like this, then you have to augment your treatment. So this is the cluster analysis, and you have the polar analysis. It is actually extrapolation. This is a structural damage. It's not the functional damage which is presented here. Longer the lines, more the damage in the RNFL. So that is the structural damage. It is a. Then you have the global indices. So I will not discuss each one here, but what is important is, just let me, I think we have less time, you have a few more minutes. I'll just go through this, it's not moving. I'll just show you the difference between the Humphreys and the octopus, and then we'll stop it. So this is the progression analysis. We need to understand there's a software which is given in the octopus that we have to use it. So the software will give the trend analysis over a period of time, how much the damage has happened. And this is the complete progression analysis chart to show that how much is the diffuse loss, how much is the local loss, how much is the square root of loss variance, and how much it is every year on year, how much it is increasing. That is called as the slope. By looking at this, we can really understand whether the patient is progressing or not. But this is something interesting again. This is done with the octopus, different octopus machine. This is done with a different octopus machine. You can do with a different octopus machine, but then again, you can see the progression. It will give you a different, one is triangle, one will be square. So we can understand which machine has been done, and then we can look at the progression also. So if we have some time, then we can discuss how we can, like octopus and Humphreys, but
I think
I'll just
you can
stop
do.
it here. We'll have the questions at least for 5 minutes. We have only 5
Yeah,
minutes.
we can.
No,
You
we
will have
started
questions
5
for
minutes
5
late,
minutes.
so we can have any questions you have, please. If you don't ask questions, that means you have understood everything, then we will ask you questions.
Sir, I think you should ask, sir. Yeah.
It's for the postgraduates. If you don't ask doubts, that means all the doubts have been cleared. So we will ask you questions to answer.
The first question will be to Dr. Ambika. She's one of the senior most ophthalmologists from Netherlands, and she's one of the wonderful persons in neuro-ophthalmology. So you have to have one question for her.
I think I
She has
spoke on
promised to take
localizing
you
the
around in the
lesions.
cruise. So ask one question.
You know my topic. It was localizing the lesions, made simple.
Anyone has any question?
Anyone? Can the eye movements be used to record the lesion in central nervous system looking at the eye movements only? Yes.
Sir, you can
Yes.
probably ask somebody who can point out with the first row, second row, something like that, sir.
Anyone? Answering question is easy.
On to the left side.
No, they are all getting. You are getting
They're all tired, sir.
tired. I think they have understood everything so much that
It goes without saying.
Okay, I will ask Ambika. See, you presented that in chiasmal syndrome, depth perception can be affected.
Yep.
The problem is the two hemispheres interconnection is in the posterior callosal fibers. That's where the stereopsis happens. Whereas chiasmal syndrome happens more anteriorly.
See, actually, it is not only the stereopsis part which is being disturbed. If you could see in a bitemporal hemianopia, we have something called post-fixational blindness.
Yes.
So when a post-fixational blindness do happen, a patient who is not, I mean, he can see at a point, but he can't see beyond that.
Beyond the point.
So that when a patient is coming down on a steps or when they do look down, so they can look at that, but beyond that they will not be able to see clearly. So that is one of the most common complaints what a patient do come up with. So here it's not the stereopsis which plays too much, or rather there can be a hemifield slide phenomena type of thing.
Yes.
If there is a pre-existing phoria, that patient will have the two fields colliding to each other,
Colliding and moving like that.
here, which will give you almost like a picture which affects your depth perception too much. That's
I
one of the
suppose-
features of chiasmal syndrome.
I suppose the global stereopsis compared to the other stereopsis,
True.
they
Yeah.
may be in different parts of the callosal
Parts.
fibers. Because brain is very complex to understand. But it is amenable to understanding also if you go logically.
True.
Sir, thank you, sir, because
Thank you very much.
GBM is going to start. I think all of them.
Oh,
have to
okay.
go.
Oh,
They will
So thank you
cancel.
so
Thank you so
much for
much.
all the speakers, and thanks for chairing, sir.
Thank you.
thank you so much.
Thank you very
All the
much.
speakers, thank you so much for, yeah, madam. I'm so happy that at least one person is asking a question.
Come to
Ask
the
a
mic.
question which we can answer, okay?
Shoot your speaker.
Related to 24-2C. I'm just a first year resident, but they asked us that there is a neuro-ophthalmic field effect in which there's an upcoming field in which 24-2C can be used as a
In neuro-ophthalmology, you are asking, you want to answer that?
No, I haven't seen what
Ronnie,
field
you are a-
24.
Ronnie, you are a
Ronnie, you have
Humphrey.
seen anything?
Ronnie,
See?
you are a Humphrey user. Would you like to answer that?
Yeah.
Use the mic, please, Rani. Or come here.
The 24-2C essentially has 9 additional points in the central area. So you get much more information from the central 10 degrees than the traditional 24-2. I'm not sure what specifically in neuro-ophthalmology they were looking at, unless it's something, a lesion which is, let's say, a centrocecal scotoma or something like that. I don't know.
Because I think most of the central scotomas we do pick up in the like 24-2 itself. And a simple Amsler will also be giving the same amount of value of 20-degree field loss. But I don't know, this extra 9 points, what extra it's going to give, unless you differentiate.
What was the entire question?
In general, if we are going to ask whether
Yeah.
24-2 program, C program, it can be done. Only thing in this is the central 10 degrees. You have a number of additional points on there. Otherwise, it is same as like 24-2.
What was the specific question?
the modality in the edge. I can't remember the exact question, but it was like there's a new modality which has an addition for neuro-ophthalmic radius, which has an additional advantage over 24-2 and 10-2. If you combine this, there is a 10-2, 24-2C region, C field, which helps you in a better analysis of a neuro-ophthalmic radius.
I think I should be able to answer this. See, the gap between 2 points in 24 and 30-2 is 6 degrees. Whereas in 10-2 it is 2 degrees. And in 24-C it is 2 degrees in the central portion and 6 degrees in the peripheral. So you can pick up smaller lesions in 24-2C. Same as 10-2.
Yeah.
But at the same time, you can see little peripheral lesions as well. The 10-2 cannot see at the mid peripheral lesions, which are better seen, which will be seen in 24-30. So you can not only pick up mid peripheral lesions, you can pick up the smaller lesions.
So that's probably true, but the thing is that for neuro-ophthalmology, one of the issues with 24-2C is that it does not actually have symmetric distribution of the additional points.
Yeah.
So that is a downside when you're looking at a neuro-ophthalmic defect, which may have, because
Usually it follows the vertical line.
Follow
so
the
this is a sort of,
vertical.
it's almost, because there are 9 points, they're not equally distributed all around. So you just Google it, you'll see the distribution, then you'll know what we are talking about.
Thank
Okay,
you.
thank you very much. All of you will have one photograph and go. Ah, ಈಗ boom ಅದು. It is. There's some light there. That's why. I can try and come. I don't want to fall down.